Good afternoon, everyone. This is Rosa. We're going to go ahead and start the webinar now. I'd like to welcome you to the Rural Health and Safety Education webinar series, Combating Opioids. This is hosted by Purdue University Extension and the NCRCRD as part of a USDA NIFA grant. Just wanted to remind everyone to facilitate questions and comments during or after. We'll be using the chat feature. Just put your questions and comments down on the bottom and we'll get to those, time permitting. So in the meantime, today's webinar is titled Adverse Childhood Experiences, a Driver of the Opioid Epidemic. This is presented by Dr. Michael Brumridge. He is an Assistant Dean for Public Health Practice and Service in the West Virginia University School of Public Health and an Assistant Clinical Professor of Medicine. And I'd like to hand it over to Michael. Thank you.
Well, thank you, and thank you very much, Rose. I hope you can hear me okay. Please let me know in the chat box if you have any trouble hearing me, and I'll be happy to adjust my position or speak up. Thank you very much. It's really a wonderful opportunity to be here with you this afternoon to talk about something that I think is very important, in that the opioid crisis is really affecting all of us across the United States. We happen to be close to the epicenter here in Charleston, West Virginia, although, of course, WVU is located in Morgantown. I'm actually located in Charleston. I'm also happen to be, by the way, the co-chairman for the West Virginia Adverse Childhood Experiences Coalition. And so we have a lot of people really looking at this as one of the root causes, one of the drivers for the opioid epidemic. So I'd ask for you to consider this picture with the infant in the upper left and ask yourself, what would it take for this developing human being who has, by all reckoning, unlimited human potential to end up in 2 short decades, maybe sleeping on a park bench, homeless, maybe with a drug use problem? So what happens in that transition from the time this baby is born to the time we have the social, economic, and health problems that we see exemplified by the photograph on the lower right? So of course, I'm going to be talking about adverse childhood experiences, and childhood trauma has really taken off. People have become much more aware of the role of childhood trauma, and even recently on March 11th, 60 Minutes, Oprah Winfrey talked about treating childhood trauma. Although she did not speak about ACEs specifically, her whole presentation was really about ACEs. So what I'm going to be referring to here is the original ACE study, and it's maybe the most important study, which many Americans are unaware of. A lot of shifting has occurred in the last few years so that more and more people are becoming aware of this, but it's largely unknown in many cases. And really the essence is that what goes unrecognized in the pediatric exam room shows up in the internal medicine exam room decades later. And when we're talking about the original adverse childhood experiences study that was done in Kaiser Permanente in the late 1990s with the principal investigators of Dr. Vince Folletti and Dr. Rob Anda, we're talking about 10 categories of childhood abuse and neglect. Now, as you're going through this presentation or listening to this presentation, you might think, well, what about poverty? What about a whole host of other issues to include violence in the neighborhood? Yes, those are all very important. We'll talk about those during the presentation, but I'll be speaking specifically about the original 10 categories of a childhood abuse, neglect, and household dysfunction. And I will actually walk you through what those questions are and how they're asked. If you want to know more about this, you're welcome to go to the website that you see on this slide, the CDC Violence Prevention ACEs study, and you can find as much information as you want in the 50 plus published studies. But this was a large epidemiologic study done with over 17,000 beneficiaries of Kaiser Permanente in Southern California. So these are not people who live under bridges or afflicted by low socioeconomic status. These are middle-class Americans belonging to really one of the better health maintenance organizations in the United States. So the connection between the ACE study findings and diseases later on and mental health problems later on in life is just profound. So compared with the people with no ACEs, those with 4 or more ACEs were 2 times more likely to smoke, twice as likely to have cancer or heart disease, 6 times more likely to be depressed, 6 times more likely to have had sex before age 15, 7 times more likely to have been alcoholics, 10 times more likely to inject drugs, and 12 times more likely to have attempted suicide. So that's people with a score of 4 or more compared with people with 0. Now, in one study looking at men with a score of 6 or more, they were 46 times, not 46%, 46 times more likely to have injected drugs than when men with no history of adverse childhood experience, or ACEs. I'll frequently refer to it as ACEs. So we know that the connection between what happens to children and what happens with mental health and with physical health as adults is profound and directly linked. So I'm going to walk you through these ACE questions because I think it's important. So everybody who's on this webinar, or any place else for that matter, by this study would have an ACE score between 0 and 10. And so for every yes answer, that's another score of 1. So for example, in question number 1, did a parent or other adult in the household often swear at you, insult you, put you down, or humiliate you, or act in a way that made you afraid that you might be physically hurt? It doesn't ask how many times it happened. It just is a yes or no question. So if you answered yes to that, that would be 1. Number 2, did a parent or other adult in the household often push, grab, slap, or throw something at you, or ever hit you so hard that you had marks or were injured? Number 3, did an adult or person at least 5 years older than you ever touch or fondle you, or have you touched their body in a sexual way, or try to or actually have oral, anal, or vaginal sex with you? Number 4, did you often feel that no one in your family loved you or thought you were important or special, or your family didn't look out for each other, feel close to each other, or support each other? Number 5, did you often feel that you didn't have enough to eat, had to wear dirty clothes, had no one to protect you, or your parents were too drunk or high to take care of you or take you to the doctor if you needed it? Question number 6, were your parents ever separated or divorced? I think it's interesting with number 6 that they don't ask about parental death, which many people rightfully say should be an ACE in and of itself, but these were the original 10 questions. And these are the ones that are most researched, which are the reason I'm walking you through these 10 questions. Number 7 is always a hard one for me. Was your mother or stepmother often pushed, grabbed, slapped, or had something thrown at her, or sometimes or often kicked, bitten, hit with a fist, hit with something hard, or ever repeatedly hit over at least a few minutes or threatened with a gun or knife? Again, domestic violence specifically toward the mother. You don't see anything here about domestic violence against the father or stepfather. Number 8, did you live with anyone who was a problem drinker, alcoholic, or used street drugs? So substance use. Number 9, was a household member depressed or mentally ill, or did a household member attempt suicide? And number 10, did a household member go to prison? So those are the original 10 ACE questions. And if you want to know more information or want to take this survey yourself, you can go and Google up NPR and adverse childhood experiences. There's a wonderful page there where you can take these 10 questions yourself, and it'll tell you what it means and what it doesn't mean.
Okay, Michael, we have
Yes.
a couple of questions. One is from Aubrey. Is there a link between ACE scores and food insecurity or disordered eating patterns?
For Aubrey's question, I'm guessing there is a connection somewhere. I don't know the literature to describe a disordered eating pattern. I'm guessing there is, but I don't know the answer to that. As far as food insecurity, I'm not aware of any literature that supports that.
Okay, and then Betsy also asked, what is the source that the CDC got the information from? Was it from the original ACE study?
Yeah, so the original ACE study was done, it was really an observation by Dr. Vince Folletti, who was an internist at Kaiser Permanente in Southern California. And he had this really profound insight into what was happening in an obesity clinic he was trying to run, where they were finding out that the people who were losing weight the most successfully were actually the people dropping out the fastest. And so that began to uncover the history of childhood sexual abuse, which then expanded out as he began to dig further and further to elucidate these 10 ACE categories. So he presented this once at a conference where it was really not very well received at all. But in the audience was Dr. Rob Anda from the Centers for Disease Control. And Dr. Anda said, you know what, this is pretty profound stuff. Let's do a much larger study. And at that time, it wasn't the original 17,000, but Vince Felitti, the internist at Kaiser Permanente, teamed up with Dr. Rob Anda from the CDC, and that's where they got the study from. Did I answer the question there?
I think you did. There is a comment regarding Missy is just stating it surprises me that there isn't a question regarding one-parent households or a missing parent.
Well, let's go back and look at that question because were your parents ever separated or divorced? And she's correct. There should be a question in there, and that goes back to the question about not only one-parent household that Missy is referring to, but also whether there was a death of one or more parents in the family. Yeah, it's a good comment. So in the next few slides, what I'm going to do is show you sort of the profound relationship between adverse childhood experiences with a number of different medical conditions here. And here you can see the people with a score of 0 all the way up to the people with a score of 4 or more. And you'll notice that, and this will be a pattern that you'll see over and over again, that women seem to be more affected by adverse childhood experiences than men are. But you can see here there's a clear linear relationship between ACE and a lifetime history of depression. Likewise, you can see that there's a very strong correlation between ACE score and prevalence of attempted suicide. And again, the risks really jump up with an ACE score of 4 or more. And West Virginia is the state that has the most smoking adults of any state in the United States, so very relevant to us here in West Virginia. The relationship between ACE score and current smoking. And then one of the ones that we're really going to spend a little more time on here, ACE score and drug abuse. And the first set of columns ever had a drug problem. The second set of columns ever addicted to drugs. And the third set of columns ever injected drugs. So very strong relationship there. And this shows up on the job as well. And if you can't read the script at the bottom of each set of columns, I'll read it out to you. This first set of columns, absenteeism, missing greater than 2 days a month. You see there's a relationship there between ACE score and serious financial problems and ACE score and serious job problems. So you know, we all have problem employees or problem people who work with us or problem bosses for that matter. And a lot of that may be, in fact, rooted in adverse childhood experiences. So this is not only problematic in terms of how it shows up in the workplace, but we are all paying for this. The lifetime costs associated with child maltreatment between $210,000 and $10,000 and $1.8 million per child. And you can see from this slide, due to all the different health, behavioral health, educational impairments, increased involvement in the criminal justice system, child welfare, social welfare systems, and lost work productivity. So this has an enormous economic burden in the United States. Not only does it have a burden for all of us, it also has a burden for the person affected by adverse childhood experiences, where you see that child maltreatment in $2,009 shows a reduction in annual earnings of almost $6,000. And that is as much as smoking, teen pregnancy, and obesity combined. So really pretty profound stuff economically as well as with health outcomes. So I'd like to spend just a moment or two on this particular slide. I really like this portrayal of a pair of ACEs that came from work from Ellis and Dietz in Academic Pediatrics last year. And so the top part of this tree is the adverse childhood experiences, where you see all the things, or most of the things that we've talked about before, domestic violence, specifically toward the mother, substance abuse, emotional and sexual abuse. Maternal depression was not included in the original ACE study, but physical and emotional neglect, divorce with one or both parents missing from the household, mental illness, and incarceration. They've also included homelessness. So that is are the adverse childhood experiences. But then when you look at the tree with a root system, you're really looking at adverse community environments. So this is this really interesting interplay between adverse childhood experiences and the other social determinants of health. So we include things like poverty, discrimination, community disruption, lack of opportunity of economic mobility and social capital, violence in the neighborhood, and poor housing quality and affordability. All of these things play a very important role. And so that's one of the things I would like for the listeners to come away with today is the idea that I'm only talking today about adverse childhood experiences, but I recognize that there's a complex interplay between adverse childhood experiences as well as adverse community environments in the other social determinants of health. Economics really drives a lot of this, specifically here in Appalachia, where we have issues with a lot of people being out of work because of the decline of the coal industry. This is another diagram that if you go onto the CDC's website, you will see a version of this pyramid on the left. So I'm going to walk you through this a little bit because I think it's good to, in a way to conceptualize what we're talking about. So we start here with this black line across the bottom, which is conception, and you end up with this arrow that goes all the way up to death. Then at the bottom, you start out with the adverse childhood experiences. And with many of our either drug-addicted children or children born to drug-addicted parents, they're walking in from the hospital through the front door with an ACE score of at least 3, just to start out with, which is really very profound when you think about it. Because we know how the brain develops, which we'll talk about briefly, that leads to social, emotional, and cognitive impairment, which then leads to the adoption of health risk behaviors. And this is, I think, a very important point because as people are developing these social, emotional, and cognitive impairments, they're looking for relief from their suffering. And so they reach out for different substances or behaviors that are going to help them cope with the kind of stressors that they've had from the adverse childhood experiences. Things like smoking. Is there a benefit to smoking? Well, as health professionals, we would say, of course not. But we know that nicotine is a psychoactive drug and that people feel a sense of relief, of anxiety when they take a puff off of a cigarette. I don't know of any smoker who is not aware of the long-term consequences, but again, it's a way to cope with the stress that they're experiencing now. Is there a benefit to taking a swig out of a bottle or shooting up? Yes, there is in the short term, but so people adopt these health risk behaviors. And this is a very important point I'd like for everybody to consider, because we tell people just say no, stop doing that kind of stuff. But in reality, what we're attempting to do is take away their coping mechanism. And you see that coping that is over here on the right-hand pyramid, which will address, sorry about that. Of course, somebody had to call me while I'm doing a webinar. The adoption of those health risk behaviors is a type of coping. So is it any wonder that it's so hard to get people to stop smoking, drinking, using drugs when this is one of their coping mechanisms? Of course, these kind of coping mechanisms, because they are health risk behaviors, lead to disease, disability, and social problems, and leads to early death, as I mentioned before. With people with an ACE score of 6 or more, we're talking on average a loss of about 20 years of longevity. So this is really very, very profound stuff. Now, some people would rightly say, what about the historical trauma that many people experience? So we'll go over to the pyramid on the right, where they talk about things that happened before conception. So if you are born into a family with African American parents or Native American parents or Holocaust survivors, then you're going to have this generational embodiment in historical trauma that manifests not abstractly in any way, but there was just a study that came out in the last few weeks that demonstrated that fathers under stress can actually transmit their stress epigenetically through their sperm by reductions of specific kinds of messenger RNA. And in the mouse model, they've done a study with both mice and with humans that in the mouse model, this lasts at least 3 generations. So it's pretty profound. So epigenetics, if you want to think about that we are all born with a certain gene set, and some of those genes are turned on and others are turned off. But through our life experience, we can turn off and on different genes, and that gets inherited then by our children. So it's really this sort of fascinating things. And then we experience, many people experience the social conditions and the local context of trauma that is all before conception. So you'll then see that the right pyramid is in many ways very similar to the one on the left. So I really like this diagram because it helps us frame the whole discussion around trauma and social location, as well as how adverse childhood experiences lead all the way up to early death. So we know that traumatic stress leads to brain alterations specifically within the first 1,000 days of life. And that's associated with increased cortisol and norepinephrine responses to subsequent stressors. So we basically prime our brains for more stress when we have stress early on in our lives. And the stress, again, that occurs particularly at a sensitive period of development can be associated with long-lasting changes in certain areas of the brain. And those brain alterations can predispose to addiction. And I wanted to thank Michelle Hirsch from Health and Human Services in Chicago for loaning these slides out to me. So in the Surgeon General's report on alcohol, drugs, and health and facing addiction in America, there's really 3 areas of the brain that are particularly important in the onset, development, and maintenance of substance use disorders, which we'll talk about briefly, which are the basal ganglia, the extended amygdala, and the prefrontal cortex. And so on this slide, you can see the effects of traumatic stress impact on the brain. On the drawing on the right-hand side, you'll see that the stress remodels the brain so that you get a reduction in the prefrontal cortex, which causes problems with executive functioning and behavioral control. You also have reduction in the hippocampus. The hippocampus is the part of the brain that consolidates short-term memory into long-term memory. So you have reduction of hippocampus with problems with memory, and then you have an increase in size of the amygdala. So the amygdala is often framed as the fight, flight, or freeze center of the brain, one of the fight, flight, or freeze centers of the brain. It really is to help us scan our environments for salient stimuli from our environments. But when it gets overstimulated, then it can actually hijack the brain. So when we come over here to this, so stressors activate the amygdala, which then drive changes in the hypothalamic pituitary adrenal axis, HPA, hypothalamic pituitary adrenal axis. That allows the brain to control our hormones with the release of cortisol. And with the release of cortisol, we get an increase in heart rate, the blood gets shunted over to the muscles, our digestive system is shut down as the blood is shunted to the muscles, and our memory is impacted. And if you've ever been so angry that you've either had a blind rage or you just couldn't think, you're so angry you can't think. That's what's happening. Your amygdala is basically hijacking your brain at that point. And so we're going to be talking just a moment about the limbic system and its role in addiction. This is not meant to be a neurophysiology lecture, but we'll talk specifically here about the cerebellar vermis and the corpus callosum, which are the connections between the right and left hemispheres of the brain. That's the corpus callosum there in the middle. And you see that the limbic system is involved with learning, memory, reward, and reinforcement. It regulates our hormones, our mood, our heartbeat, and our sexual behavior. So again, with the hippocampus and amygdala, you have problems with attention and memory and social cues. And when the amygdala hijacks the system, you have increased panic and fear. With the cerebellar vermis, which we talked about, you have emotional perception, attention, and it plays an important role in addiction. And the corpus callosum that I pointed out to you before has multiple processing and integrating functions. But the exposure to childhood trauma really has a negative and lasting impact, and it predisposes us to substance use and addiction. And we not only know this from the neurophysiology, we also know this from a number of large studies epidemiologically. So in the original 1998 ACE study from Kaiser Permanente, they found people with an ACE score of 3 or more had a much greater likelihood of engaging in substance abuse, domestic violence, and suicidal attempts, were more likely to be obese, have dropped out of school, be divorced, have diabetes, cancer, and heart disease. So basically, most of the major public health problems that we face in the United States, and that seems to play out predominantly here in Appalachia more than in other places. And again, the ACE score of 6 or more with 4,600% or 46 times more likely to use intravenous drugs relative to an ACE of 0 in that one study of men. In a 2009 study, over 80% of patients seeking treatment for opioid addiction had at least one form of childhood trauma, almost two-thirds having witnessed violence in childhood. In 2016, people with an ACE score of 5 or more were 3 times more likely to misuse prescription pain medication and 5 times more likely to engage in injection drug use. So I'm really fond of what one of my colleagues at West Virginia University, Alfgeir Christensen, who was really involved with the Icelandic experiment that you may have read about in the Atlantic. I won't talk too much about that here. But basically what he's saying is that if you walk into a nursery with 100 babies and you ask somebody which one of these children are going to grow up to become addicted, and everybody would say, well, how can you tell? It's kind of a crapshoot. Well, it's not a crapshoot at all when we understand that people with a high adverse childhood experience score, people who grow up in certain neighborhoods or in certain zip codes, are more likely to be predisposed to misusing prescription pain medication, which of course was the precursor to the injection drug use problem that we have today in the United States. So it's really pretty profound stuff, and I'm really trying to share this information as much as I can with as many audiences as possible. So I'm just going to talk to you briefly about a little survey. KCHD stands for the Kanawha Charleston Health Department, which I was the health officer there for 2.5 years. We wanted to start a conversation about adverse childhood experiences in West Virginia, specifically in Kanawha County, Charleston, West Virginia. So we did a little survey. It was a web-based tool, basically a Survey Monkey tool, and we announced this through press releases, radio, and television announcements. So the prerequisites is that you had to have seen that through television or media and had to have access to a computer. So this is not meant in any way to be a random survey or a scientific survey of our population. But because we had so many respondents, I thought it was worthwhile to share it. It's really important to know that we want to look at ACEs as a risk factor. It's not necessarily a predetermining factor, it's a risk factor. So just like we know with high cholesterol, that there are some people who have high cholesterols, they never get heart attacks or strokes. We also know that there are people who get heart attacks and strokes with very low cholesterols, but on a population basis, that there's a relationship. In the same way with adverse childhood experiences and the connection between adverse childhood experiences and health outcomes. And in our case, we're talking about opioids, opioid abuse, and injection drug use. And another sort of pitfall I wanted to be very careful about is not to blame or shame parents for the issues, because they may have raised their children with ACE scores of 0, and yet their children abuse IV drugs. And so we have to be very careful about how we label parents or mislabel parents. And that was really important to apply some compassion when we look at these kinds of data. So here's the results from our informal survey. You can see that we had 506 respondents. 76% were female, only 24% were male. So you know right away it's not a representative survey for the population. 95% were white, but West Virginia is a 95% white state. You can see that most of the respondents happened here. This is Kanawha County, where Charleston, West Virginia is, where you see the arrow. Next door is Putnam County. Next to that is Cabell County, where Huntington, West Virginia is. Huntington, classically considered across the United States now sort of the worst affected community. And by the way, I think they're the community that's really turning things around faster than anybody else. But most of the people who answered the survey lived along this I-64 corridor. We're basically in the same media market. We had respondents from around the state of West Virginia, 46 respondents from Monongalia County, where Morgantown is. Had some of my WVU colleagues disseminate this out, and 10 from Ohio County, which is where Wheeling, West Virginia is. But we had a smattering of people who answered from other states, including some in the Midwest, Virginia, Ohio and Michigan. Most of the people were between ages 25 and 65. And I'd like to spend just a couple moments here on this particular chart. Now, this part of the chart that I'm outlining here with the green arrow, this particular chart I took directly from the CDC's website. So I just wanted you to know where that came from. And we have a number of adverse childhood experiences with 0, 1, 2, 3, and 4 or more. And then you'll notice here it's broken down between women and men. So you'll notice across the board that women have a higher ACE score than the men do, but then you have this total. So we're going to spend the last couple moments on this slide looking at the totals across the board and comparing it with KCHD, which is the Kanawha-Charleston Health Department's survey of 506 respondents. And you'll see that the number of people with 0 was actually lower than it was in the original Adverse Childhood Experiences study from San Diego, California. And you'll notice also that much higher number of people with a score of 4 or more. So a couple of really important points here is that the majority of people that we meet on a day-to-day basis have an ACE score of at least 1. And from the original Kaiser Permanente study, if that's to be extrapolated across the population, it's been, now this survey has been replicated in many other communities, by the way, usually with higher ACE scores of 4 or more, but that's 1 out of every 8 people with a score of 4 or more. So it shouldn't be surprising in many ways that we have sort of the adverse outcomes that we have, but this is pretty remarkable, 28.2% with a score of 4 or more. So ACEs are common and they're really relevant to our public health problems that we have. I don't know if any of you had a chance to read this book. This is called Hillbilly Elegy by J.D. Vance. It's a New York Times bestseller. It's an autobiography. I bring up this a lot because it has an Appalachian connection to it. J.D. Vance grew up in a place called Middletown, Ohio. Middletown was a industrial town halfway between Cincinnati and Dayton, Ohio, where there's a large Appalachian diaspora. So in the history of Appalachia in the 50s and 60s, as the coal industry was declining, a lot of people migrated from eastern Kentucky, southern and southwestern West Virginia to find jobs in heavy industry in places like Akron, Ohio, with Firestone Tire, many of the heavy industries in Ohio, to Detroit, Michigan, to work in the auto industry. But you had this large Appalachian diaspora who felt much more culturally close to their roots in Appalachian. That was for J.D. Vance. He calls himself a hill person. So the gist of the book is that J.D. Vance grows up in a house where his biological father, leaves the house at an early age. His mother brings in a number of men into the house. She begins abusing alcohol. She begins to use prescription drugs. And by the end of the book, she has become a heroin addict. As I'm reading through the book and reading this sort of horrible things that happened to him growing up, I'm starting to add up his ACE score, because that's what I do. Adding up his ACE score was 6. So by all reckoning, J.D. Vance should have had a terrible time later on in life. But the rest of the story with J.D. Vance is that he went to the Marines after he graduated from high school. He came back, he went to Ohio State University, where he graduated summa cum laude a year and a half early. Went on to Yale Law School, where he became an editor at the Yale Law Review, one of the preeminent legal journals in the United States. And eventually, by the end of the book, becomes an attorney for an investment bank in Silicon Valley. So J.D. Vance beat the odds. So what was the thing that helped him do that? Well, what became clear from reading the book is that he had his mama, what he called his mama and papa, his grandma and grandfather, who always lived close by, so that no matter how much dysfunction was happening with his mother in that household, his grandparents were living close by and he could escape to a much safer environment. So it brings out a really important point that what really matters to help mitigate adverse childhood experiences is the presence of another human being who provides unconditional love, guidance, and a sense of psychological safety. Now, Mama was no model citizen by any means. She carried around a loaded pistol everywhere she went and was rumored to have set a man on fire in eastern Kentucky, which is kind of funny in a way, but sad in another. But the point is that it didn't matter to him. He knew that she would go to the mat for him and help him in any way that he needed to later on in life. So really important point about the role of adults in shaping the future of children affected by adverse childhood experiences. So what I'm going to do here is focus in on this one last chart. And this is another chart that I took directly from the CDC's website. And you can see here that this is another one that breaks it all down. So what we're looking at is the total 17,337 people from the original adverse childhood experiences study, broken down by men and women. And you can see on these columns, these are the different categories: abuse, neglect, and household dysfunction. These are, as you can read from looking at the chart, emotional, physical, sexual abuse, and on down. And then you have these numbers, which are percentages. These are percentages. And again, you can see that percentage-wise, that women seem to be disproportionately affected across most categories, not all. But we compared this with a group that we did a survey on. This is not the Kanawha Charleston Health Department group. This is from a harm reduction clinic, a syringe service program. These are people who are actively using intravenous drugs. So we surveyed 199 of them to kind of see where their ACE score stood out. And outside of these two categories, which is really interesting, physical abuse and sexual abuse, which were very close actually to the original adverse childhood experiences study, across the board, the numbers are really much, much larger. And in this case, incarcerated household member in the original ACE study, 4.7%, 28% among those who were visiting our syringe service program had a score of, had this particular category, excuse me. And again, this is from a harm reduction clinic, HRC, syringe service program. This was interesting too, in that the original study had 36.1% with a score of 0. We actually had 33.7 with a score of 0, which surprised me a little bit, suggesting that there's another mechanism why people begin to use IV drugs, end up using IV drugs, getting in with the wrong peer group experimentation. But this was really astounding too. In the original study, 12.5% had a score of 4 or more, and in our cohort, 39.2% had a score of 4 or more, which really speaks to that. There's a bimodal distribution here where you have a lot of people with a score of 0 who, wandered into this by experimentation perhaps, and then another group who's really dealing with profound pain. It's just remarkable, some of the stories when you sit down and talk to these folks, and it really helps break down a lot of the stigma that we have toward people who use IV drugs. So going back to adverse childhood experiences, once again, just as an overview, 3 categories of abuse, 2 of neglect, 5 of household dysfunction. So my question is, and I'm particularly aimed at my medical colleagues, why aren't we asking these questions? Since they seem to be so relevant to the public health problems that we see today. And a lot of it is, I think, has to do with the time that providers have, and it's just one more thing they have to do in their busy day. But another is, so what do we do if we find this kind of stuff? Well, we know that there are now a number of evidence-based interventions that can help reduce exposure to adversity and strengthen resilience to adverse circumstances. We know that, for example, home visiting programs are effective at reducing child abuse, neglect, domestic violence, and improving health outcomes for children and parents. There's a very specific one called the Nurse-Family Partnership, with a 48% reduction in rates of abuse and neglect, 56% reduction in emergency room visits, and 79% reduction in children days hospitalized with injuries and ingestions during the first 2 years of life. So again, it's this whole idea that people who may be having struggles parenting, because they themselves are dealing with the effects of adverse childhood experiences from their childhoods, and people tend to parent the way they were parented themselves. So it's not only about looking at the children, it's also looking about the parents and how to strengthen that entire family unit, whatever that family unit is, whether it's simply mother and child or children, father and children, grandparents and children, whoever's looking after the child, strengthening those partnerships. And by doing so with home visiting programs or with nurses who are visiting in the households. There's another evidence-based intervention called the Positive Parenting Program, or Triple P. This is an intervention that provides parents with tools to raise their healthier children and deal with stressors. We know that also that telemedicine works, teleparenting works as well in another study. But in triple P, they were demonstrated to reduce rates of child maltreatment by over 20%, and they decreased the out-of-home placements and childhood injuries. And right now in West Virginia, at least, this is a true plague. The foster care system in West Virginia is completely overwhelmed, and it has to do mostly with the opioids that are out there plaguing our communities. Another intervention is parent-child interaction therapy, and it's a tool to assist parents to improve the quality of the parent-child interaction and relationship, and showing to reduce child abuse in participants versus individuals with control conditions and a long follow-up. So I think it's really important to recognize here that it's not high-tech stuff that's going to make a difference. It's that basic interaction that parents have with their children or adults have with children that are really making a difference and can have really profound outcomes to help turn this around. As well, there are a number of non-pharmacologic practices that we can use for both children and adults. We know that exercise is really a magic elixir of sorts. It helps us regulate our heart rate and our blood pressure. We talked about the hypothalamic pituitary adrenal axis, the HPA axis. It helps us with the regulation of that, decreases depression and anxiety, helps us regulate our cerebral neurotransmitters, including dopamine and serotonin, and we release endorphins, some of our natural opioids inside of our body. And then there's mindful-based awareness training. Mindfulness, it's a very popular subject nowadays, but in many studies has been shown to help regulate heart rate, blood pressure, the HPA, just like exercise does. It also has really sort of very interesting anti-inflammatory effects. Studies that were done with people with psoriasis have shown that when you added mindfulness-based interventions to their regular treatment, they healed faster than those who did not receive the mindfulness. And then it helps also decrease post-traumatic symptoms. Let's see, I've lost the ability here to go on to the next slide. There we go. Thank you. So this is my conclusion slide, and what I want to tell you is that adverse childhood experiences are very common, as you've seen, but they're often completely overlooked. We're so consumed with this opioid crisis, with all its different manifestations, that we don't often take the time to look back on what is really driving us in our society today to have to reach for things that alter our reality. Reality as it is becomes boring, unsustainable, painful in some way, and a lot of that is really rooted in adverse childhood experiences. And we know that what's overlooked in the pediatric exam room, the classroom, and other places shows up in our courts, our emergency departments, and on our streets. So it's really, I think, incumbent on us to really take a deep look at this as a really root cause, not only to the opioid crisis, but to many other public health problems that we're seeing across the United States. And I think this is really, really important, because if we understand, if we truly comprehend that a lot of people are using IV drugs, it helps us shift the dialogue from what's wrong with these people to what's happened to them. When you ask somebody what's wrong with you, you're implying that there is something inherently defective about them as a human being. When you start talking about what's happened to somebody, that allows for a space of compassion to come in, not only for the people who have this negative self-dialogue about themselves, but also to the people asking the question. So we're so stuck in this vicious cycle of stigma with profoundly bad judgments of people who use IV drugs. And often there's a lot of bad feelings toward these people, because they've often stolen from people they know and love, they've abandoned their children. But understanding that this is really running in the background for many of them is really an important point. And this allows us to shift our perspective from judgment to compassion. So in any case, that is my presentation. I've done it in 45 minutes or 46 minutes now, and I think there are probably time for questions.
Thank you, Michael. This is Mark Skidmore. Thanks to Rosa for starting us off here. Thanks for the presentation. You can see there are a few comments down below, Michael. If you'd like to respond to any of those, you can now. And for those of you who are on, you can ask questions as well by typing in your comments or questions.
Okay, I'm looking back through some of the comments. From Betty Swenson, going back, follow up, sorry, we have been trying to find more linkage between ACEs and opioids by way of data and other than the original ACE study that happened in 1999. We don't have much. That's what prompted the question. Wonder if there are more recent data. Ms. Swenson, I hope I answered the questions, and I'm sorry you couldn't see some of the content on the slides. Allison Brennan added in the original ACE study. Thank you, Ms. Brennan. Nancy Forg, can you please provide the name of the study on epigenetic and RNA compromise for the last 3 generations in mice? I would have to probably go and look. I recently read it in Psychology Research or something like that, but I could probably find that a little bit later on. Ms. Brennan add the book to the reading list. We're talking about Hillbilly Elegy here. Ms. Woods asked if we can ask for participants. We always ask for participants to complete adverse childhood experiences study. Unfortunately, mental health care providers are as overwhelmed as DCES is right now. We try to provide a support. Well, thank you for doing that. Getting people to a parenting class is hard, Tim. Yes, it is very hard to get people. It's really interesting. The people who are most afflicted by adverse childhood experiences have been so marginalized and so stigmatized, not only for substance use, but for a whole host of other things, and often also happen to find themselves on the lower rungs of the socioeconomic scale. So there's a distrust of systems of care that have worked against them. So it's really about building trust first, and I think getting them into parenting classes. But I don't know of any parent who doesn't want to do what's best for their children at that point. But it's a matter of just building a level of trust. Ms. Brennan answered Tim's question. And David Young had a comment. Sadly, embedded in our criminal justice system is an underground trauma to prison pipeline. ACE scores of our incarcerated populations is off the chart, especially in women's prisons. David, and one of the slides I actually cut out of here was one through a public defender one, where there were 10 cases and only one person had a score of 1. Everybody else was 4 and above, and it was heavily weighted towards 7, 8, and 9s in that one. So absolutely, you're right. It's part of our trauma to prison pipeline. Dinah Torres Castro need to make parenting classes mandatory. Yeah, I think there's a really important reason to incentivize that, which I'm sorry, I'm going to have to. I forgot to silence my phone before I started. Yeah, incentivizing parenting classes is really important. And Pat Brinkman answered on to that with incentives. And I think teleparenting can also help along with that too for people who are open to that, but it's not a magic elixir either. Tim Mahoney wrote, I think one of the hardest issues to transcend in social trauma from child protective service criminal issues is the degree to which we continue to inflict trauma as institutions. Maybe it would be useful to move this effort from health providers to judges, legislators, and state agencies. Thanks, Tim, for that comment. In fact, I have given this talk now to different sets of attorneys and judges, and it's been very well received. In fact, now I'm finding, interestingly, that more judges and legislators are knowing about adverse childhood experiences than many of my medical colleagues, which is a sad statement to say. But that's one of the purposes of the Adverse Childhood Experiences Coalition in our state, is really to educate, to advocate, to coordinate, and to educate. And talking to legislatures is one of those. And we were able to get trauma-informed legislation into our last legislative cycle. Let's see, Jill, inviting parents to a class that includes a meal and childcare as well as incentivize improves parenting engagement. Very good. Thank you, Jill. And Allison responded to that. Parenting education is good, but insufficient. It needs to be supplemented by parental support. Yeah, so I think this really goes back to the whole thing that we try to do. We're trying to educate our way out of the opioid crisis. We teach people that doing drugs is bad, but that psychoeducational approach is actually very, very limited. Um, we need to engage with people and let them know we're there for them. If you want to really have people address the things that are often hid by time, shame, and secrecy, we really need to find a way to develop a trusting bond with those folks. And that requires a little bit of extra time, and it's not really amenable to an office visit with a provider. You can uncover those things in an office visit, but it requires the nurse or other concerned people who are trained on your staff to be able to sit and explain why this is important. Often people don't see that connection, though, between their parenting behaviors and what's happened to them themselves. And once they can piece that together a little bit, many of them do want to change. They just don't know how to do it. In the words of Vince Felitti, parents do the best they can with what they know until they know something better. Let's see, I'm down here. How do you educate the public about ACEs and convince them that drug users need help and compassion? Jackie, it's a really great question. There's a whole effort around trying to address the stigma. We even have a website now as part of our opioid combating efforts in West Virginia called Stigma Free WV. And so it's just one of those things we have to keep talking and talking and talking about because there's such a heavy stigma associated with drug use, even here in West Virginia where so many people are affected. Samantha Hoyt wrote, when you discussed other explanations for substance use in your study, you mentioned peer group and experimentation. Can you talk more about that? Were those your top two explanations? How does that change treatment evidence-based programs that may be needed? Well, it wouldn't really change the treatment other than those are not people that need to really be focused in on trauma-informed care, but finding ways to deal with them as individuals with medication-assisted treatment or peer-based treatment. We didn't do a deeper dive, Samantha, honestly, into why the people with the score of 0 end up with the score of 0. That only became evident after we asked and compiled the data. So I wish I had a better answer for you than that. And I'm sorry I couldn't do better with that answer. Esther Lynn Duvall wrote, any comments about what is happening on the border with children being taken away from their parents? Seems like we are causing trauma for the next generation. Esther, you're absolutely right. That's exactly what we're doing. And that was one of the comments that I saw from a pediatrician, and I think it was in the Washington Post this weekend, talking about that we are inflicting another adverse childhood experiences on these kids. And we know we're hurting children with what's happening on our southern border. Liz Andrus, my comment is families belong together. Yes, if we can have families belong together, that's absolutely the best possible outcome, because functional families will help buffer the effects of other experiences on the children. Tim wrote, I think we have to decide, is addiction a crime or an illness, and act accordingly. I don't think we can do both as we are currently doing. And I couldn't agree with you more. I think we need to really treat it as an illness. There is a role for interdiction and of police support. But what's really encouraging, Tim, to me is to hear lifelong law enforcement officials saying we're never going to bust our way out of this problem. And I think that shows some insight. We've had a war on drugs, labeled war on drugs, since the Nixon administration. And our efforts against drugs have gone back even further than that, back to a guy named Harry Anslinger in the 1920s. So we're almost 100 years into this problem. And we keep doing something over and over again that doesn't work. We have failed miserably in our approaches, which is why I'm really trying to find time to talk about adverse childhood experiences and how this really affects us as a society. Allison wrote, it's hard to watch the increasing budget cuts for extension systems who do valuable work related to health and wellness, parenting, and positive youth development. They're out there every day doing prevention work, but they keep getting their funding cut. So yes, Allison, you nailed it. And so one of the other things we hope to do by talking about ACEs enough is to make the point that if we want to turn the tide in the opioid crisis, it's not only about medication-assisted treatment, treatment beds, intensive outpatient therapy, which is the best medication, naloxone to save people overdosing. It's about going to where the root of the problem is. and to talk to our elected representatives at the local, state, and national level, to talk to them about these are not touchy-feely, feel-good sort of social worker programs. These are programs that are really at the crux of turning the corner. And the other point that I'd like to make too is that if we understand that, we know that there are no quick fixes to this. We're talking about generations before we can really turn this around. I hate to sound negative in that way, but we need to really emphasize to our elected officials that funding these programs that seem like touchy-feely, extraneous programs are really important.
Well, Michael,
okay,
I hate to interrupt this great discussion, but we are sort of getting close here to the end. And as I hear the questions and all of your great responses, in the back of my mind, I'm thinking of the movie Good Will Hunting, which I think in some ways embodies a lot of what the discussion is what the discussion reflects. I wonder if we can find a way to summarize, Michael, and then close up. I know some are starting to thank you for the great webinar, and so do you have a closing remark and maybe one more response to anything that you see on the chat?
Well, thank you, Mark, for this opportunity to speak with so many people that I saw who attended the webinar. I just want to make a mention again that adverse childhood experiences are extremely common. They're extremely relevant to the opioid crisis that we have in our country. And that if we want to turn the corner, we have to pay attention to this one particular issue. It is the issue, I believe, of our lifetime, not only with respect to the opioid crisis, but with many other vexing public health issues that we have, so that we move away from treating the symptoms to really treating the underlying disease. That's true primary prevention.
Right. Well, I think with that, we will go ahead and end the webinar here. Thanks again, Dr. Brumage, for coming on. Thanks to all the participants for joining in and the great comments. Also, thank you for those who have filled out the feedback here that we have on the screen. That's very helpful for us. And if you haven't, please take a moment to do that. And with that, I just want to again say thank you, and we'll see you next time. We will not have another webinar as part of this series until September, so we'll be back in touch with you with updates as we approach that time. So again, thanks again, Michael.
Thank you very much. It was a pleasure.